Well, thank you. It's a true honor and pleasure to be here. And I really enjoyed both of the presentations that just came there. And I hope that all of you are seeing that um, many of us have to wear a lot of hats in order to try and address the very much interdisciplinary nature of the problems that are facing us in this world. And 2 weeks ago, I was just speaking at a UN conference in Thailand that was trying to look at the interlinkages of the Sustainable Development Goals. How many of you are already familiar with Sustainable Development Goals and what that term means? So the world really did a good job of trying to create these different tracks of issues, energy and health and education. And so it was like all of these world leaders were together saying, well, how do we look at the interlinkages? And the fact is, these problems are all interlinked problems. And so the fact that Kanara, as a physician, is thinking about the health of forests, and I, as a physician, you'll see, is thinking about energy access, I think is just testimony to the fact that problems are inherently interdisciplinary. And I hope that by listening to stories like ours, it will really start to inspire some of you to just sort of look at the kinds of problems that you want to address in the world and don't really think about whether it's in your toolbox right now, whether you have the skills, because you'll see, Kanari took her passion to really try and address something she didn't know how to address. And actually, my story is very similar. So I'm going to now start by taking you on the journey that I'm on, and I'm sure we're going to have a really fruitful discussion when we speak as a panel. So to start, I want to take you not to a hospital in Boston, but I want you to imagine that you're one of the 15 million women this year who suffer a pregnancy complication, but you don't have access to a hospital like the ones that surround us here. You're actually by yourself in a hut in northern Nigeria. You have not had prenatal care. You're for hours on a dirt floor by yourself in labor. But even though you don't know much about medical care, you realize after 2 days that something is really wrong. And you convince your family to pull together the resources to get you transportation, to bring you to the nearest hospital. They barter, they trade an animal for the ability to transport to a hospital. You make an arduous journey. Your family knocks on the door. A midwife ushers you into the hospital, tries to understand why you're bleeding so heavily, tries to figure out if your baby is still alive or not, tries to think of how she can bring a doctor to conduct a C-section to save your life. And this is the only light available in the hospital. This is the grim reality for millions of women around the world. It's part of the reason why women like these in northern Nigeria also face a very high maternal mortality. In sub-Saharan Africa, women face a chance of dying around 1 in 38 in their reproductive years, meaning that a young girl knows that her chance of dying from complications of pregnancy and childbirth are quite high. So Zainab, you were mentioning that Sudan had a maternal mortality rate. I actually looked it up while you were speaking. It's over 1,000 women are dying for every 100,000 live births. So I'll put that in perspective. Here in the United States, it's about 20. We'd love it to be zero, but you can still see that there's a huge order of magnitude. So I was a graduate student at UC Berkeley after being an obstetrician for many years, and I was asked to go to northern Nigeria. That's where this picture was taken. And at the time I arrived there, the rate of women dying was 3,000 per 100,000 live births. In fact, the lifetime risk of dying there was 1 in 13 for these women, which meant that everybody knew someone who had died from childbirth, either within their family or a neighbor or a sister. So it's just completely different than my own experience. I have been working as an obstetrician in San Francisco for many years, and I always thought of childbirth as a very happy and healthy event. And the thing that also really struck me when I went there is that women are not dying of rare diseases. They're dying from the same complications that I had learned to treat during medical school residency and as a physician. Things like hemorrhage and obstructed labor, where a baby's just too big to fit, infections, and also not having access to legal abortion is another reason. So why are so many women dying? Fatima gave us one clue. She talked about early child marriage. So imagine someone who's 12 years old trying to carry a baby when her own pelvic bones haven't really become large enough to deliver the baby, and then not having an access to C-section. Well, part of it is lack of education, lack of access to health care, And when a complication does occur, most of these women are trying to have their babies at home, and it's very hard to reach life-saving care. But when they do reach hospitals, like this one that was in a hospital in northern Nigeria, they still may not get the care that they need. So I was a graduate student at UC Berkeley, as I mentioned, and I was asked to join a project in northern Nigeria. And it was only for 2 weeks. They said, just go and observe care. We know that many women are not surviving even once they get to the hospital. And they said, don't even read about medical care there, just go and observe. And so I spent 2 weeks in this hospital trying to see what the doctors were facing. Now, you'll see there that you see electricity lines, there's grid electricity, and that white thing behind the surgical ward is actually a generator. And this is where I spent most of my time. This was labor and delivery, a far cry from what I was used to in my own hospital. On the right, you're seeing metal tables. There's no mattresses, pillows, there's no monitors. And in fact, there was no electricity for 12 hours of each day. And I had anticipated that the care would be very different than what I was used to, but I had never really thought about what it would be like to be a physician or a midwife and not have electricity. Well, it means that surgeries like C-sections are conducted by the ambient light of light from windows rather than using the overhead lights that may not have power. They may not have cautery machines to try and coagulate blood vessels or suction machines they can use. It means that women coming with hemorrhage may not be able to get an immediate transfusion because there is no blood bank refrigerator, because that requires 24-hour-a-day electricity. So women like this one who do have hemorrhaging require a family member to come in, get tested, see whether they have any infection, see if their blood matches, and only then would they be able to get a transfusion. And that could take at best hours and sometimes days, and there was tremendous loss of life. In fact, at this hospital, which did 150 deliveries every month, when I got there, there were 3 to 8 women dying every single month from complications of pregnancy and childbirth. It also meant that there was no mobile communication system. If you can't charge cell phones or have an intercom, when someone needs an immediate C-section, there's no way to immediately assemble a team. So this was a woman who had a condition called placenta previa. The placenta was covering the cervix, and the only way to deliver the baby safely was to have a C-section. And as an observer, I came in when they had already been waiting for a doctor for 2 hours by sending a messenger to physically look around the hospital compound. And after 4 hours, I said, look, I'm going to have to do something. So I ran and started banging on the doors of people's homes who I knew were physicians, finally got someone, brought them back, but by the time we got there, it was too late. She had lost her baby because the placenta had delivered first and the baby had no blood supply. And I saw situations like that repeatedly in those first 2 weeks. And at night, this is what the maternity ward looked like. This is a midwife sitting in a large state hospital. There's rows of patients that are behind her on either side, mothers with babies, family members there, and everyone's in pitch darkness. And there was a night like this that I was in the labor ward actually watching a woman who had a condition called eclampsia. Her blood pressure was high, she was having seizures, and I was sitting in the corner of a very dark room, and I said, she's going to die like this, in silence, in darkness. And I had to ask myself, why am I here right now? Why am I bearing witness to what I thought was basically a chamber of horrors? And I said, these women have no voice. No one is speaking for them. Here I am, a physician coming out of a fantastic public health school. I had no idea this problem was happening. Maybe other people don't know, and maybe if people do know, they would do something about it. And that was a night that changed my life. I began to write stories home to family members about what was happening. And I have the good fortune of being married to a man who was actually very interested in solar electricity. He was creating solar electric programs for young people in California to try and make solar energy really accessible and joyous to them. And as I told him the stories I shared with you, he said, look, come back, let's design a solar electric system for the hospital. And I said, that's great. And I came home, and it's a longer story, but there was a competition at UC Berkeley where we actually applied for funding. And though we didn't get first prize, one of the judges called me later and said, what do you need for this project? And actually helped me get funds through UC Berkeley to fund this. But I said, you've got to come with me and tell people there about solar electricity. Just as Kinara was talking about listening, it's really important to get buy-in from the people that you're working with. And I wanted to make sure the thing we thought about was something that would be appealing to them. So I said, please come. And he said, no, you just showed me all those pictures and I heard the stories. I'm really scared of going. You're going to need to learn about solar electricity. And so what he created was a miniature demonstration kit that I could literally put in my suitcase, smuggle through customs, and bring to northern Nigeria to show my colleagues to say, hey, what do you think of this? What do you think of solar lighting? What do you think of using walkie-talkies? In those days, which was about 10 years ago, cell phones were not as ubiquitous. So we brought in solar-charged walkie-talkies. We brought in headlamps. I showed them the lights. And they said, you need to leave this kit here. And I said, no, you're going to get a much bigger system. We're actually bringing in something to power the whole operating theater and the maternity ward. And they said, you don't understand. This will help us right now. So I left it in place, but I did bring back a bigger system. The operating theater went from looking like this to this. And the amazing thing was all those lights only used up 15 watts of power, less than you would see in a normal incandescent light bulb. We brought in a blood bank refrigerator, and over the next year, maternal deaths went down by 70%, and the hospital was able to admit more women, 16% more women. Now, there was no organization, there was no We Care Solar. There was my husband and I and a few graduate students and a bunch of people that were just interested to follow this. But what happened was people from the hospital started bringing me to other clinics, and they looked at me and said, why are you only helping the big hospital? We are also delivering people in the dark. And so we had to do a little bit of soul searching and say, well, how are we going to solve this issue? We don't have, as I said, an organization. And then we thought about that demonstration kit that I told you about and said, what if we just brought a little bit of solar equipment each time I go back to Nigeria? And so that's what we did. We started making solar suitcases, which were sort of suitcase-sized solar electric systems that had a lot of the components of the big system, but just things I could package literally to smuggle in. Well, word spread. We started getting more and more requests for these, and this is what my backyard looked like at the time. We had an assembly line, and if you looked inside the house, it looked even worse. I mean, that was what every room in the house looked like. With the help of a larger grant from UC Berkeley and a MacArthur Foundation grant, we were able to design a solar suitcase that could scale and make them actually in much larger quantities. And so this is now what a solar suitcase looks like. There's a solar panel. There's very high efficiency lights. We have a fetal Doppler, a monitor to listen to a baby's heartbeat. You can charge cell phones, you can charge laptop computers, and you can use rechargeable headlamps. So what does it mean to have light? It means that midwives now can have light through the night to do deliveries, that they no longer have to fear going to work at night. It means that midwives are able to charge cell phones so they can assemble a team when it's needed. It means that you have a fetal monitor to listen to a baby and decide who needs a C-section and who doesn't. And it means that C-sections and other surgeries can happen throughout the night without sending people away. But any technology is not enough without having some kind of an education program. So initially I would go clinic to clinic trying to teach people, and sometimes we would reach places, this is now in Sierra Leone, where I was introducing them to electricity for the very first time in this village. So what you're seeing in the window is actually the chief and all of the people just like trying to see what electric lights were about. So it was fantastic to be introducing something that was sustainable like solar electricity as their first exposure. But again, we needed to scale up this, and so we began having midwives themselves doing some of the educational programs. And then they started asking, well, why aren't we putting in the solar panels? So we realized we should get them up there doing the installations as well. And that led to a program that we called the Women Solar Ambassador Program, where we solicited women from around the world to do an in-depth training with us, creating a train-the-trainer model. So these women got trained both in maternal child health in terms of how to collect data and how to work with midwives, as well as solar electricity and installations. And then they, in turn, would go out and do trainings in Africa and Asia as needed to build local capacity, so that we worked with district health technicians and partners in lots of agencies to try and allow them to get the skills and knowledge to be able to both do installations and to maintain these systems. And here's just a selection of some of the partners that we've worked with. Using this model, we've been able to reach more than 3,000 health centers around the world. The countries that are in yellow are ones where we've done pretty significant partnerships, bringing in hundreds of solar suitcases. We're now doing a program in Liberia in partnership with the Ministry of Health, where we're trying to get assurance that every single health center in that country has a reliable form of lighting for maternity care. We're calling this initiative Light Every Birth. Uganda just signed on to the same initiative last month, and it's one of the things that I go around the world talking about when I go to places like the UN. The other thing that we're doing is we're displacing fossil fuel forms of energy. So kerosene lanterns I showed you already, diesel fuel generators are also being displaced, candlelight as well. So we're actually decreasing carbon output as well. And the other thing I want to tell you is that there's lots of other ways in which solar suitcases can be valuable. So you're all familiar with the Ebola outbreak that happened in West Africa. Well, imagine, in addition to being worried about whether you're being exposed to a life-threatening illness, not having light to be able to do these examinations, or even being one of the people in checkpoints trying to decide who should be passing through from one district to another and not having light when you're trying to assess who's sick or not. So we sent solar suitcases out in that situation. Other types of natural disasters also have huge impacts on energy access. This is a picture we received from one of our partners that does maternal child health in Nepal, and it was after the earthquake in 2014. And this was one of their logisticians climbing an avalanche after the earthquake to try and bring light to this health center. And we realized that after things like natural disasters, in this case, the earthquake in Nepal, there's tens of thousands of pregnant women still needing care. And so we actually started a program where we've now brought in hundreds of solar suitcases, both to try and help health centers that may no longer have access to electricity because of impairments from the destruction from the earthquake, and also ones where they've actually erected now tents to try and provide emergency obstetric care because there is no functional health center there. So the solar suitcase has been very effective there. Now, part of the reason we're all together is talking about women and how we can affect planetary health. And Zainab talked about the importance of education and educating youth. And we think that's important too. And if we're going to have women being very active as leaders, we need to start actually at a younger age. So we have an education program. It's called We Share Solar. We're bringing solar education into schools so that young people can learn about energy poverty and can learn that they too can be solutionaries. We're doing this both at the high school and middle school level, and we're actually doing this as well in colleges and universities, where we're using college students to be mentors to some of these young people. And they are building solar suitcases not for healthcare, but for schools that also lack access to reliable electricity. And so we are now doing programs where we're connecting some of the students in one country with students in another. And I actually just got back. This is Kakuma Refugee Camp in Kenya. You were seeing pictures before of a girls' school. But I just got back from Uganda, where we did our first education program with Ugandan teachers so they can teach their own children to be making solar electric systems for their communities. And where we can, again, we try and promote women as installers so young people get that model as well, that women should have as much exposure to things like engineering and being electricians and installations as their male counterparts. So I'm going to finish with one of my favorite stories. This is a story of a doctor. He's actually in the orange t-shirt. His name is Dr. Jacques Sebasaho. And he is a family practice doctor who has a clinic in a small island in the DR Congo. It's called the island of Ijwi. And he contacted us one day, my husband and I, saying, I heard about your solar suitcases. I'm in New York for a day. I'm based in California. And he said, I absolutely need this, and I'm going back to the DR Congo in 2 days. And I said, there's no way we can do this. And my husband, who says yes to everything, said, yeah, we'll overnight ship it to you. So we ended up teaching him over Skype how to use the system. And I said, the moment you get to the DR Congo, call us. I don't feel like we've given you a really in-depth education. I want to make sure we answer your questions. And I didn't hear from him for 5 weeks. And I was sure that maybe the equipment was confiscated in the airport. When he finally called, he said, I'm so sorry to have delayed the return call. He said, the day that I got to the clinic, there was a woman delivering twins, and I have to say the lights really made for a successful delivery. But the next day there was an outbreak of cholera. And for the next 30 days, I took care of 122 mothers, fathers, and children with the disease. He said, in the past, I used to lose 50% of my patients to cholera, and 80% of those deaths happened at night. He said, for the first time in the history of this island, no one died. He said, we are witnessing what light means in communities where night means death to those in need of emergency care after the sun goes down. So at the beginning of this talk, I asked you to imagine that world of darkness. But now I want you to imagine a world of light. Imagine that every community, like Dr. Jacques Sepesaho's community, does have a sustainable form of electricity that they get to control. Imagine that health workers are no longer worried when they go to work at night whether or not they're going to have light. Imagine that mothers don't have to bring candles or kerosene as part of their birthing kits. Imagine that we could light every birth. I want every one of you to know here that I've shared this journey with you, but at the very beginning, I had no idea what I was getting into. And each of you are going to be exposed to things, particularly if you do work abroad, where your only decision is whether or not you want to address that little problem that's in front of you. You don't necessarily know where it's going to go. We are now really working on an initiative lighting up births around the world in partnership with groups like UN Foundation, actually, that was one of our strongest allies early, now the United Nations. Lots of things are possible as long as you find the thing that I think you can find most passionate to you. And if any of you are interested in joining us on this journey, please talk to me at the end. I would love to include you. Thank you.